Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, June 27, 2024, we are speaking to Dr. Raphael Landovitz, who is professor of medicine and interim chair of infectious diseases at UCLA Medical School. Dr. Landovitz joined the UCLA Care Center in 2006 after training at Harvard Medical School, where he also was medical co-director for the Vietnam CDC Harvard Medical School AIDS Partnership in Ho Chi Minh City, Vietnam. He's an infectious disease and HIV clinician with both a clinical and research interest in HIV and STI prevention, particularly the use of chemoprophylaxis as part of HIV and STI prevention, PrEP, PEP, and microbicides. He is a leader in the NIH-funded ACTG, HPTN, and ATN clinical trials networks, and he was awarded the John Kerry Young Investigator Award by the ACTG in June 2020 and the HIV-MA HIV Research Award in 2017. He led the NIH-funded clinical trials that supported the 2021 FDA approval of long-acting injectable cabotegravir for HIV PrEP. And today, we're going to review the latest information on HIV prevention via PrEP. Rafi, welcome to the podcast.
Thanks so much, Dr. Saag. It's a pleasure to be here.
Okay, so let's get started. For those of you who are kind of unfamiliar with the concept of pre-exposure prophylaxis for HIV, maybe you could take us through a brief history of how this all started and bring us up to where we are today.
Sure. Thanks for the opportunity to provide a little bit of background, because it's sort of fascinating, or I think it is anyway. The idea really came from observations from early on in the epidemic, before we had good HIV treatments for people with HIV. Healthcare workers and others who would be exposed either through needle sticks or splashes of blood or body fluids from people who were living with HIV. And again, I want to be clear that this was before good treatment was available. There was an observation that if you took components of antiviral regimens that we use today and took them after an exposure like a needle stick or a blood splash, you could prevent somebody from getting HIV as a consequence of that exposure or that splash or that needle stick. And the efficacy of that intervention was really dependent on a number of things, but one of the more critical elements was the timing between that exposure and the administration of the medication, the dosing. So the time to dosing interval. And so how would you best minimize that time from the exposure to the dose, but actually to have the medication on board before the exposure ever took place? So it was that sort of notion that led people to study this idea for people who might be at risk for repeated exposures over time, to use medication dosed on a regular recurring basis in anticipation of those exposures as a technique for preventing HIV acquisition. And it was based on that PrEP was born. The first efficacy studies that showed an effect, or that signaled an effect, that led to regulatory approvals were resulted in the early 2010s that ultimately led to a 2012 approval for the first set of medications, a combination of tenofovir disoproxil fumarate and emtricitabine. Brand name is Truvada, right now available as a generic. And that being used daily had very high levels of protective efficacy against HIV acquisition through a number of routes: rectal exposures, vaginal exposures, intravenous, parenteral exposures, but all predicated on being able to take it as prescribed on a regular basis. And that led to the initial challenges with the need for expanding the concept of PrEP beyond a daily oral medication to sort of second generation usages of those initial medication products and additional products, including more recently longer acting and injectable products of PrEP that have come to expand it. But that's how it all started.
Yeah, and I'm a little chagrined to say this, but in 2010 or so, when these initial studies came out, I thought, wait a minute, why are we spending, it could be up to $1,000 a month to prevent the infection, when if we just had a little bit more focus on other prevention approaches, we wouldn't necessarily need it. And I, within a short period of time, pivoted and said, yeah, I get it, because this is an ounce of prevention to a pound of cure situation. So, as you mentioned in the beginning, it was TDF, or tenofovir dispivoxyl fumarate, we'll just call it TDF, or tenofovir alafenamide, or TAF. Those are the two anchors, but they all had FTC or emtricitabine with it. As you mentioned, these were not 100% effective, because you'd think that if you're taking that medicine, it should work. So why didn't it work 100% right off the bat?
Yeah, great question. So the initial result, the randomized trial result, which was done in cisgender men who have sex with men and transgender women, so really looking at predominantly what was rectal intercourse, had a point estimate for the protective efficacy of 44%. And a lot of people were really disappointed in that. But of course, devil's in the details. And the details were that it was really challenging at that early stage in the development of PrEP for people to buy into the idea of taking a pill, as you said, on a daily basis. And so people didn't do that. In fact, only about 50% of the pills that were given out in that original phase 3 study were actually ingested by anybody in the study. So, when they did post hoc analyses of that initial trial, it became very clear that, the medication itself is highly effective, but you have to take it for it to work. So adherence was the overwhelming reason for that initial point estimate of, 40-odd% reduction. And if you looked at a subset of people who had evidence of daily dosing, it actually was more than 99% protective, again, for these rectal exposures. Now, again, some of the studies in cisgender women, in whom overwhelmingly we presume that the route of exposure was vaginal sex, we don't have quite as rigorous data, but still definitely a dose response effect. And that may be, in this particular case, mitigated by the fact that the components, this TDF and FTC that you noticed, the TDF in particular, concentrate about 100-fold less well in the female genital tract than it does in rectal tissue. So there may be, in addition to this notion of you need to take it as prescribed, also less forgiveness in the female genital tract for this particular medication. And I make that point because that really needs to be evaluated for every new PrEP medication, because it's likely to not be true for different medications. They're going to partition, if you will, differently into rectal tissue versus the female genital tract. And that's going to contribute to forgiveness to misdosing and probably overall efficacy as well. So, again, some of the trials in cisgender women that suggested non-efficacy initially or limited efficacy, depending on which trial you looked at, probably all can be boiled down to those two things. The differential ability of these medications to get into the location most likely to be of exposure. And also they had a really hard time, particularly in Southern and Eastern Africa, finding a medication dosing regimen that worked for people, right? Yeah. And, again, because you have to take it for it to work, it has to be congruent with your lifestyle. So it has to be discreet enough that you're going to want to take it. It has to be something that is convenient enough that you can accomplish it. And it has to be something that rises to a level of priority in your life enough compared to other things like living, eating, taking care of your children, going to work, that you are willing to prioritize focusing on that. And that is really, turns out, a complicated, nuanced, and multidimensional consideration that I think probably the early trials didn't take into consideration quite as much as they needed to.
Yeah, it's funny. there's an old adage that says medications don't work unless they're taken. I don't know
It's
where that came from.
funny.
It's
That's
sort of
funny.
true.
Yeah.
So let me push back just a little. I don't want to spend a lot of time, but just maybe for a minute, because when I think about tissue penetration, fine, I get the dynamics you described, but to me, what happens at the time of initial exposure and infection is that it's an activated T cell, in my view, that's the prime source of infection. And maybe it's a resident T cell, whatever, but those T cells are circulating. They're not just hanging out in one place; they move in and out, and that the protection, as long as the drug's getting into the T cells to prevent them from becoming infected, that to me is a rate limiting step. You want to push back against that, or do you agree with that?
Yeah, I think the T cell infection is definitely an important point here. I think we don't have a completely full and nuanced understanding of what the correlates of protection are. This is just one hypothesis that people put forward as a potential explanation. I think you're right. There are a lot of things that we don't fully understand about this, including some observations about how well drug gets into PBMCs and other circulating cells when administered topically. So this probably is a story that remains to be fully answered. And when we talk about injectable PrEP, I will tell you that this observation of differential tissue partitioning again comes into play with the observed results. Whether or not that's just a bystander for other reasons, we don't fully know.
Yeah, and I might have oversimplified this because there are resident macrophages in these areas that could be the initial location of infection, and then it spreads from there into T cells. Well, you mentioned long acting. So, but wait, before we get to that, you also mentioned that about half the time people are taking it, maybe because they aren't focused. So Jean-Michel Molina, especially in France, came up with this notion, I think, based on some of these early observations, and said, wait a minute, if somebody's not having sex every day, let's say it's once every 2 weeks, that they might have an exposure, maybe we could just make this episodic PrEP. So can you briefly go over that and what the 2-1-1 regimens are?
Yeah, I was sort of alluding to that earlier with these sort of other sort of ways of taking existing medications. So this is, to date, we only have data for, again, TDF, FTC, and we only have data in cisgender men who have sex with men and transgender women for this context. So that's the setting. And yeah, Jean-Michel Molina, who I kind of have an intellectual crush on, let me be completely clear, was very smart, and he made a number of observations. He looked at this, less frequent dosing that had high levels of rectal protection, more forgiveness. He looked at some animal models that were compelling in this regard, that episodic dosing might be possible. He looked at some really interesting pharmacokinetic data that suggested that if you took a double dose of this TDF FTC upfront, you could get rectal tissue, again, to your point, maybe not the whole story, but a provocative story nonetheless, concentrations that were thought to be protective within as fast as 2, but within 24 hours of a double dose of this medication. And also the observation clinically that a lot of people were doing this technique that was colloquially called disco dosing. Someone would be planning to go out to the disco on a weekend night, and so they wanted to sandwich that planned sexual activity around dosing and minimize dosing when they weren't likely to have an exposure, and minimize toxicity and cost, and having to remember to do something when it wasn't warranted in that context. And so since people were doing it, he thought it would be wise, based on all of these considerations that I've mentioned, to get some data. So he did a randomized controlled trial. As you noted, it was called IPERGAY. It was done in France and Canada, Quebec in specific. And it randomized, again, these cisgender men who have sex with men and transgender women to either TDF, FTC, or a placebo with this, as you mentioned, 2-1-1 dosing scheme. And that refers to the number of tablets of the TDF, FTC taken really on an every 24-hour schedule for a very limited amount of time. The idea being, if you can plan that you're going to have planned sexual activity on Saturday, I'm making up these dates, 2 to 24 hours before that planned activity on Friday, you take a double dose of TDF FTC. The sexual activity happens 24 hours after that first double dose. You take a single dose. That's the second one of the 2-1-1. And then 24 hours after that second dose, you take a third and final single dose. That's that final one. So that's 2 doses, 1 dose, 1 dose. It's called 2-1-1. It's called pericoital. It's called on demand. And the primary result of that study was 86% reduction in HIV incidence for the people who got the active drug. Now, the caveat of that is, right, sometimes people don't just have that one episode of planned activity, right? Sometimes there's more activity on Saturday, maybe on Sunday, maybe again on Tuesday. And so the thing that I think sometimes gets lost in this 2-1-1 notion is if people are continuing to have ongoing activity, you need to continue every 24-hour single dosing until 48 hours or 2 single doses after that last planned activity. So as you were alluding to, Mike, right, if somebody is having, more than more sex than, really once or even twice a week, it very quickly degenerates into what is effectively daily dosing anyway. Yeah. So it becomes 2-1, 1-1, 1-1, 1-1-1.
and so forth. So let's move on to longer acting drugs. This is where you led a pivotal clinical trial that really was revolutionary in terms of how it changed things. And the logic, just to pick up on what you were saying, is that if you can have continuous exposure to a medication over a long period of time, you don't need to do episodic dosing. You don't have to worry as much about adherence because you'll have injection of a compound that'll last 2 months on average, then just get your shot every 2 months. So that's cabotegravir. Take us through that experience from your perspective as the study leader. And I'd love to go into all the details of how you planned it. That could be 3 more podcasts, but maybe just the punchline about how this all turned out.
Yeah, no, thanks. So the origin of this and the motivation was exactly what we've been talking about, right? You got to take the medication for it to work. So, having it need to be something that you do daily or some sort of planned, dosing around, known or planned sexual activity, complicated. So can you take some of that activity, some of that requirement out of the picture, and, you show up in your clinic every 2 months and you get a shot and you don't need to do anything else and you're protected. That's sort of the ideal. The ideal probably is, some sort of long-standing immunity even to infection. But since we're, 40 years on in the epidemic and we don't have a vaccine yet, that's what we're trying to emulate, right? Some long-term protection, longer the better. So this product, seemed to have pharmacokinetics that suggested a 2-month dosing interval. So that's how it was studied. It was studied in a randomized controlled trial compared to daily oral TDF FTC across populations in 2 different large studies. I led one of them. And the punchline is both studies were stopped early for really superior levels of HIV prevention efficacy in the injectable product compared to the daily oral product. A lot of people say to me, does that mean that if both products were taken exactly as prescribed, that that the injectable product is actually better than the oral product? And the answer is, we didn't do that study. This is how it was taken. And the truth of daily oral tablets is people don't take them exactly as prescribed, because otherwise you'd have very high levels of prevention efficacy. It'd be very difficult to show superiority to that. And so to me, the take-home message of this is a long-acting injectable product covers sex acts better than a daily oral product. They both work really well if you take them as prescribed. If you're going to struggle with taking a daily oral pill, something that takes that behavior as a requirement of it working out of the picture is going to have a better chance of keeping you HIV negative.
And just for comparison purposes, the success rate over whatever it was, 48 weeks or longer, of the cabotegravir single injection every 2 months was in the 90%, right, range?
Yeah, it's very difficult to know that exact answer to that question because there was no placebo arm in any of those trials. If you do some, magical thinking and some counterfactual estimates, yes, it's about 94, 95% protection compared to nothing. What we actually found in the studies for the cisgender men and transgender women is it was 66% lower HIV incidence rates than the people who got the daily oral TDF-FTC. And for the cisgender women, it was 90% less HIV incidence than the women who were randomized to get the TDF-FTC. Again, not an exact science to calculate what a placebo comparator would have shown.
So despite the success of this, which is really quite striking with the cabotegravir, you stumbled onto something relatively new. It's a new syndrome called the LEVI syndrome, and it doesn't refer to what kind of genes that the patients are wearing, but it's a specific breakthrough of low-level viremia that's kind of hard to pick up. So can you tell us first off what LEVI stands for and how you check for it and what you do about it?
Yeah, thanks. This was a little unexpected finding when we got the original results of 083 and ultimately 084. It stands for long-acting early viral inhibition. And the idea is that when you have a long-acting antiviral in the system, the normal burst of HIV viremia that we see in classic conventional primary or acute HIV infection that causes the mononucleosis-like syndrome that we see in about 70% of people and ultimately generates or causes the body to generate antibodies that lead to our more conventional HIV diagnostic tests turning positive, all gets muted, delayed, and attenuated. So because you have a long-acting antiviral in the system, instead of this burst of viremia, you have a very low level, smoldering level of viremia, often right at the level of detection that sometimes it's detectable, sometimes it's not detectable, and it can be very confusing. Is it true positive? Is it false positive? What does it mean? And also the generation of antibodies is then delayed and attenuated, and you can get this flickering of these antibody results also. All that to say that with these long-acting products in the body, the conventional way that we diagnose breakthrough HIV infection becomes a lot more complicated. You can diagnose it earlier by using RNA or viral load testing. But again, because as I mentioned, it's right at the level of detection. That can sometimes be confusing and also really difficult to disambiguate from a false positive result. Because what's good about those viral load tests is they're more sensitive. What can be problematic if you're doing them very frequently is that they're more sensitive, less specific. So I think it's a story that remains to be told. If this actually is helpful or not helpful going forward as part of a strategy to monitor for breakthrough infections with these long-acting PrEP agents. And I don't think that this is going to be a phenomenon that's limited to long-acting cabotegravir. I think every long-acting PrEP product in the future is going to have this challenge. And to me, the take-home message, whether or not it turns out viral load is the right test, is we need better HIV diagnostics that are more sensitive and more specific to help us detect these breakthrough infections with these long-acting PrEP agents. And in particular, the reason this is particularly important is because the longer you sort of allow HIV to incubate, if you will, or smolder in the presence of antivirals, then you could get resistance to those antivirals. And if they're part of your treatment regimen, that complicates your treatment. Also, potential complications in transmission onward, particularly in things like the blood supply, right? Where, even if we're screening by RNA or antibodies, right, and you miss low levels of it, is that an opportunity for a new route of transmission? Probably not sexual transmission because these viral loads are very low, but these other more nuanced mechanisms is something that I worry about a little bit.
Yeah, but to keep it in context, the LEVI syndrome is not common. You saw it in out of a couple thousand people, well, how many times? Maybe 6 times?
We've seen it 6 times so far in the cohort that's been reported. The incidence rate of this syndrome is incredibly low. It's somewhere around 0.15 per 100 person years. So you're right. These failures are rare. LEVI is rarer. And at least in the cisgender men and transgender women, seems to only happen if it's within 6 months of the last cabotegravir injection. It's likely different for cisgender women because the pharmacokinetics of this particular drug are different for cisgender women. It may be longer, but it is rare. You're 100% correct.
Yeah. So we only have a few minutes left, but it'd be remiss if I didn't talk about the future a little bit. And in particular, there are other long-acting agents, and just dated this podcast to late June of 2024. And just about a week ago, we saw a press release from Gilead about their long-acting product, lenacapavir, which is not just given IM every 2 months like cabotegravir is, but it's given sub-Q every 6 months, which makes things almost vaccine-like because it's relatively easy and it appears to be potentially efficacious. Tell us what you saw in the press release and what your holdbacks are, your reservations, but on the other hand, assuming it is working, what your predictions are for the future.
Yeah. So this is all very much in evolution. And, depending on when somebody's listening to this podcast, we may know a lot more already. But as of today, and I'm glad you dated the podcast, which is about just almost exactly a week after the press release came out, here's what we know. That this is a study that was done in cisgender women in Southern and Eastern Africa. And the DSMB for that study, which was a randomized study of these cisgender women to either this every 6 month lenacapavir, daily oral TDF FTC, or daily oral TAF FTC. There were 0 reported HIV infections in the lenacapavir arm. There were 16 incident infections in the TDF FTC arm, and there were 39 incident infections in the TAF FTC arm. Now, that's a little deceptive because the randomization in that study was 2 to 2 to 1. So there were twice as many people randomized to the TAF FTC and the lenacapavir arms as the TDF FTC. So it's a little deceptive. The incidence rates that were reported, they did a counterfactual placebo based on an assay called a recency assay, not tried and tested, but we're going to see how that plays out. The incidence rate in that counterfactual placebo is estimated at 2.41 per 100 person years. The incidence rate in the TAF FTC arm was 2.02 per 100 person years, and the TDF FTC was, I think, about 1.69 per 100 person years. And of course, in the lenacapavir arm, if that holds up, 0. So if that's true and that's real, that's tremendously exciting. What we don't know to date is, did they account for LEVI? How long was the follow-up? It seems pretty short to me based on when the study finished enrolling. So that's going to be really important to look at. And what was the safety and tolerability of this injectable subcutaneous product? I think we don't know a lot about these subcutaneous PrEP products, and hearing more about how it was tolerated and discontinuations is going to be really the next step of fully knowing how to interpret this. But preliminarily, super exciting result.
I mean, it really, if you let your imagination go wild, which is pretty easy to do when you see 0 infections, it really does become something that can almost make the notion of not having a vaccine right now quite attractive to use this approach. Because let's say we had an effective vaccine right now. We don't know exactly how long that vaccine protection is going to last, and it's going to be years before we would know exactly how to use the vaccine. But we could be using the lenacapavir or another long-acting preparation, even cabotegravir. So it's interesting how it's all playing out. Well, our time is up. I'm going to give you the last word and then we'll wrap up, but just kind of your summary thoughts on where we are in PrEP and what it's been like for you to jump on this horse back about 10 years ago and ride it into the sunset today.
I like that analogy. I've never been on a horse in my life, but I guess this is the closest I'm going to ever get. It's a really exciting time to be in HIV prevention, really for the reason that you described, Mike. I mean, we still are unfortunately far away from a vaccine. Even if we had one, we'd still be learning about it for a long time and the durability of its protection. Now we've got a number of highly potent, highly effective options that we can offer to people. There are a number of other ones that are in early or even moderately advanced stages of development. A monthly pill had a little bit of a setback last year, now back on track with a new product. A bunch of topical preparations, douches, threads, films, rings, lions and tigers and bears, oh my. There's lots of exciting things on the horizon that we'll have to sort of wait and see, but more options are going to be better because there's going to be a product that is going to work for somebody. Because regardless, we sort of coming back to the first thing we talked about in this podcast, which is, you got to use it for it to work. And so whatever product it is, it's got to be acceptable and tolerable and consistent with the way you live your life. And it has to be affordable, and we have to be able to get it to you consistently. So lots of challenges so far. Those last two things I mentioned, the affordability and the access and the getting it to the right people at the right times and the right places has proved much harder, I think, than people would like to admit. And that needs to be a focus of our ongoing work in parallel with just developing these new products.
Well said, and a great way to wrap up. Thank you for being with us today. This was a fabulous podcast, and we'll have you come back sometime in the not too distant future to give us an update. Thank you, Rafi.
Sounds great. Thank you for having me.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.